A very important topic today, and I think we have the chairperson who can introduce the speakers, and we can start the meeting. Neeraj, you want to say something?
No. Just welcoming all for this season 5 and 6 of our Saga of Epilepsy, and it's a fantastic topic. So everybody will have academic feast. I'll invite Pramod, chairperson for today, Pramod Krishnan, who is from Bangalore. He needs no introduction, and he will introduce the speakers and start the the topic.
Good evening all. Welcome to this session. We'll be focusing on some important concepts, the plus syndrome, pseudotemporal epilepsy and paradoxical temporal epilepsy. And to enlighten us on these important topics, we have Dr. Soumya, who will be talking about temporal plus epilepsy, and Dr. Shalini Bhaskar, who will be talking about pseudotemporal epilepsy. Sorry, am I audible?
You are audible, sir.
Yes, you are audible. Yeah.
Okay, because I thought the screen froze. Okay, Dr. Soumya, you're currently in Trivandrum, right? She did her Chitra Tirunal Institute of Medical Science and Technology. She's a budding epilepsy specialist. So we'll hand over the stage to her to expound on this important concept. Dr. Soumya, over to you.
Thank you, sir. Good evening, everyone. Before starting my presentation, I would first like to thank Ashalatha madam for giving me an opportunity to present a topic in this platform. So without much ado, I will go on to my topic, the temporal plus syndrome. So as we all know, this temporal lobe epilepsy, one second. Okay. This temporal lobe epilepsy, we know that among the temporal lobe epilepsies, around 30% are drug refractory and will require a surgical management for control of seizures. However, the success of this temporal lobe epilepsy surgery will depend on correctly identifying the epileptogenic zone. It has been found that the median proportion of long-term seizure freedom post-surgery in temporal lobe epilepsy patients is around 66%, and this percentage further drops down to around 33.8% after anti-epileptic drug withdrawal post-surgery. So there are various reasons for the surgical failure in temporal lobe epilepsy. The first reason being incomplete resection of the pathological temporal lobe lesion. The second reason is an independent contralateral temporal lobe seizure onset, which accounts for around 18 to 21% of the temporal lobe epilepsy cases as studied by depth electrodes, and less than 20% of failed temporal lobe resections. And the third and the most important cause is an incorrect localization of the ictal onset zone, under which comes the pseudotemporal epilepsy and the temporal plus epilepsies. So I will be dealing with temporal plus epilepsies, and Dr. Shalini will be talking about pseudotemporal epilepsies. So the concept of temporal plus epilepsy was first suggested by Rivlin and Kehane in 2005. So it was found that around 27.5% of TLE patients undergoing stereo EEG have temporal plus epilepsy, and this constitutes around 10% of the patients undergoing the standard temporal lobe surgeries. So this concept can be explained in two ways. The first is the default concept. So as per default concept, the temporal plus epilepsy refers to specific forms of seizures with multilobar origin, which are characterized by involvement of complex epileptogenic networks, including the temporal lobe and its closely neighbored structures like the orbitofrontal cortex, insula, frontal operculum, parietal operculum, and the temporoparieto-occipital junction. So to understand this concept better, we should know the important white matter association tracks in human brain. The important ones include the superior longitudinal fasciculus, the inferior longitudinal fasciculus, the inferior fronto-occipital fasciculus, the arcuate fasciculus, and an uncinate fasciculus. So these are the 5 major white matter association tracts in human brain. So I'll be just talking in short about each of these. First, coming to the superior longitudinal fasciculus, it is composed of 3 major components, the SLF1, 2 and 3. The SLF1 connects the superior parietal cortex to the SMA as well as to the dorsal premotor cortex. So the superior parietal cortex is mainly involved in identifying the location of the body parts in a body-centric coordinate system. So this SLF1 is mainly involved in motor programming, and it selects the appropriate motor action from a competing set of motor programs. And SLF2 connects the caudal inferior parietal cortex to the dorsolateral prefrontal cortex. The importance of this is that it is a bidirectional pathway, and since the caudal inferior parietal cortex is involved mainly in spatial attention and visual and oculomotor functions, this SLF2 feeds the dorsolateral prefrontal cortex with the data as to how to perceive each of this visual as well as visual space around the particular individual. And the next is the SLF3, which connects the supramarginal gyrus to the ventral premotor and the prefrontal cortex. The next important tract is the inferior longitudinal fasciculus, which connects, which is the major occipitotemporal association tract, and it forms the backbone of the ventral visual stream or the VOD pathway. So it connects the ventral anterior temporal lobe to the extrastriate cortex of the occipital lobe. So it is mainly involved in object recognition as well as in face recognition. Next is the arcuate fasciculus, which we all know connects the Broca's area to the Wernicke's area, and it is important in language, and the lesions of which will result in conduction aphasia characterized by impaired repetition. Next is the inferior fronto-occipital fasciculus, which connects the frontal lobe with the occipital and the temporal lobes, and it is mainly, its main function is of this particular fasciculus is the semantic language processing. And the next is the uncinate fasciculus. The uncinate fasciculus, it is a hook-shaped bundle of fibers which connects the anterior temporal lobe to the inferior frontal gyrus, mainly the orbital gyrus. And it is the fasciculus which allows the mnemonic representations which are stored in the temporal lobe to help guide decision making in the frontal lobe. And it also has an important role in learning as well as memory. So among these 5 different fasciculus which I have described, of importance in temporal lobe epilepsy is mainly the last 4 ones, that is the inferior longitudinal fasciculus, the arcuate fasciculus, the inferior fronto-occipital fasciculus, and the uncinate fasciculus. So first we'll see how these networks are of importance in temporal plus epilepsy. So these fasciculus, so the temporal lobe through these fasciculi have connections with 4 major areas. One is the orbitofrontal cortex. Next is the insula and the operculum. Next is the perisylvian cortex. And the 4th one is the parieto-occipital cortex. So based on which we have 4 identified clinical subtypes, electroclinical subtypes of temporal plus epilepsies, namely the temporofrontal, temporoinsular, temporoperisilvian, and the temporoparieto-occipital. And the ictal manifestations will depend on which network and which network is involved in each of these subtypes. So coming to the next concept, so this is the default concept. The next is the observational concept.
Yeah, it is working, Soumya. You continue.
It is not going forward, sir.
Okay.
Okay. Yes. Next is the observational concept. So based on this, the temporal plus epilepsy refers to specific forms of epilepsies which are characterized by prominent involvement of the temporal lobe. That means the electroclinical features primarily suggest a temporal lobe epilepsy. However, there will be some red flags, electroclinical red flags which are present. However, and the MRI, if we see, will be like will have unremarkable findings or may show subtle signs of hippocampal sclerosis. However, the intracranial recordings in these patients will show ictal discharges which are originating simultaneously from the temporal lobe as well as from the neighbored extratemporal structures which I have already explained. Or these patients may have two coexisting seizure types in the same patient, with one having an temporal ictal onset and the other having an extratemporal ictal onset. So this is the observational concept. So based on this, what we finally understand is that to make a definitive diagnosis of temporal plus epilepsy, the diagnosis mainly relies on invasive EEG recordings. And when we have to plan invasive EEG recording in a patient who is suspected to have temporal lobe epilepsy is when the electroclinical features are mainly suggestive of a temporal lobe epilepsy, but with electroclinical red flags, which I will be dealing with in the next slides, and with the lack of any definite MRI abnormality. So this is a landmark paper which was published in Brain in 2007, and this group studied 80 patients with non-lesional temporal lobe epilepsy. And they classified the patients into two groups. One is purely temporal and the other into temporal plus based on the stereo EEG recording findings. So, and among these two groups, they have compared the ictal clinical findings as well as the scalp EEG findings. So, what they have found is that in temporal, in the classical temporal lobe epilepsy, as we expect, these patients, this group of patients will have an ability to warn at the seizure onset, and they exhibited the classical 4 A's of temporal lobe epilepsies, that is the abdominal aura, gestural automatisms, behavioral arrest with paucity of motor manifestations, and post-ictal amnesia. On the other hand, the temporal plus epilepsy patients exhibited some of the electroclinical, like some clinical red flags, mainly in the form of gustatory hallucinations, rotatory vertigo, auditory illusions among the auras, and presence of autonomic features like ictal piloerection, and presence of ictal motor manifestations in the form of contraversive manifestations of eye and or head, and ipsilateral tonic motor manifestations, and post-ictally they exhibited dysphoria. So these constellation of symptoms were identified as the clinical red flags for temporal lobe epilepsy. And while comparing the scalp EEG findings, they found that precentral and bilateral interictal abnormalities, as in contrast to the typical frontotemporal blunt sharp wave seen in temporal lobe epilepsies, were present in temporal plus patients. And the ictal onset in these patients were beyond the borders of temporal lobe, that is mainly from the frontal anterior, fronto-precentral or temporoparietal areas. So this is how they have tried to differentiate the temporal plus epilepsy from the classical temporal lobe epilepsy based on the ictal clinical manifestations and the scalp EEG findings. So now coming to the diagnostic approach in temporal plus epilepsies. So first will be the clinical approach, and the first aim of this clinical approach is to identify the electroclinical red flags, which I have already explained. And then we have to correlate it anatomically. So among the auras, the presence of gustatory auras and somatosensory auras, mainly in the form of laryngeal discomfort or throat constriction, a feeling of throat constriction, bilateral hand paresthesias, perioral paresthesias, trunk paresthesias, all these will point towards a temporo-insular subtype. And the presence of vestibular auras, like the feeling of the rotatory feeling, will point towards a temporo-parieto-occipital subtype. Presence of auditory aura towards a temporo-perisylvian subtype. And presence of olfactory auras to a temporo-frontal subtype. And among the motor manifestations, the presence of these contraversive head or eye deviation, ipsilateral tonic motor signs will point towards a temporo-frontal type. And the presence of unilateral or bilateral sensory or motor manifestations in the perioral region or the chin will, along with the presence of anarthria, drooling anarthria or motor aphasia, will point towards a temporo-opercular involvement. And presence of autonomic features like piloerection and cardiovascular alterations, as we all know, will point towards an insular involvement. So this is the first step, that is identifying it clinically. Now coming to investigations, the first line investigation will be a scalp EEG. So earlier studies which were conducted during a period from 2000 to 2004 by various authors, they have found that the temporal plus epilepsy patients more frequently showed precentral and bilateral interictal abnormalities. And also, the location of the first ictal change outside the borders of the temporal lobe was significantly associated with temporal plus epilepsies rather than the classical TLEs. However, later studies which were done by Barba et al. In 2007 have found that neither this temporal lobe interictal spikes nor the ictal EEG onset helps definitely to rule out a temporal plus epilepsy in any of these patients. So this underlines the need for a detailed evaluation, especially with invasive monitoring, to make a definitive diagnosis of temporal plus epilepsies. So as I have already told, the imaging findings, the MRI, may be negative or nil contributory in most of the cases. So special imaging modalities will be required, of which the diffusion tensor imaging is of much use in temporal lobe epilepsy, because they will help to identify which particular association tract is involved in each of these patients. So DTI will help, the stratigraphy studies will help in lateralization of the epileptogenic focus, and it also helps to delineate the key white matter pathways for surgical planning. For example, the optic tracts, so that we can avoid resecting that area. And it also reveals subtle alterations in the white matter microstructure, both proximal and distal to the epileptogenic focus. And a lower fractional anisotropy values, increased mean diffusivity, and increased degree of asymmetry in fiber tract, this fractional anisotropy to mean diffusivity ratio, that will indicate that there is a disruption in that particular tract. That is how, through DTI, the pathological tract has been identified. And functional imaging studies like PET are also of much use in pre-surgical evaluation of these patients. And in them, it will show temporal hypometabolism, ipsilateral to the atrophic hippocampus, involving the middle and the superior temporal gyrus, uncus and the parahippocampal gyrus, along with one of the extratemporal areas like the lingual gyrus, inferior parietal lobule, supramarginal gyrus, pre or post central gyrus, the frontal gyrus, the rectal gyrus, or the insula. So, so these are the important investigatory modalities in temporal lobe epilepsy, temporal plus epilepsies. In addition, another emerging modality is an EEG fMRI continuous monitoring. So this helps in identifying the irritative foci for further study with more invasive techniques like a stereo EEG to identify the exact location of the epileptogenic region. However, the shortcoming of this modality is that it can identify only the interictal changes, and ictal changes cannot be definitely identified by this modality. So next one is the MEG, magnetoencephalography. So MEG detects the mesial temporal spikes in around 85% of the patients with mesial temporal lobe epilepsy. So among the MEC subtypes, it has been found that the magnetometer is superior in recording spikes from the mesial temporal lobe, whereas a planar gradiometer, which identifies the potential difference between two regions, is superior in detecting spikes mainly from the temporal neocortices. And among the dipoles which have been identified by MEC, the horizontal dipole will localize the source more towards the temporal tip or the lateral temporal regions, and vertical dipoles to the basomedial temporal sources. So this is a study which has compared the three modalities, that is magnetoencephalography, MRI, and the ictal video EEG monitoring, that is invasive ictal video EEG monitoring, and its ability in predicting correctly the epileptogenic zone and identifying the site to be resected for epilepsy surgery. So it was found that the MEC was second only to ictal intracranial video EEG in predicting an epileptogenic zone, and the same relation was seen in temporal lobe epilepsy patients post surgery, and with extratemporal resection, this the same relation was again seen, and the margin was much higher. That means the ictal and interictal intracranial EEG could identify correctly the epileptogenic zone in 81% and 75% of patients respectively. However, MEC could identify it only in 44% of the patients. So the invasive EEG monitoring is always superior to MEC. And coming to the stereo EEG monitoring, so it helps in adequate spatial intracerebral sampling of both the temporal as well as the extratemporal structures. The temporal structures, temporal lobe structures which are sampled in stereo EEG monitoring includes the amygdala, hippocampus, parahippocampal gyrus, the external capsule, superior, middle and inferior temporal gyrus, and the temporopolar region. And the areas which are sampled in extratemporal, the extratemporal structures which are sampled, it is based on which subtype of temporal plus epilepsy we are suspecting in that particular patient, that you can see in this slide. And to conclude, the diagnosis of temporal plus epilepsy requires high index of suspicion with prompt identification of the electroclinical red flags, which I have already explained. And an adequate pre-surgical workup should always include a 3T MRI, video EEG, followed by invasive recordings if there is a discordance and suspicion of temporal plus epilepsy. Thank you. Not able to use.
Yeah, you can stop sharing it.
Yes.
And Dr. Shalini, you can start.
Yeah.
Yeah.
Sure. Thank you so much, Chairperson. I'm very grateful to Professor Ashalatha, Madam, for giving me this opportunity to participate in this lecture program and deliver this talk. Okay. Today's presentation will be on pseudo-TLE and temporal lobe, pseudo-temporal lobe epilepsy and paradoxical temporal lobe epilepsy. It is estimated that about 30% of TLE cases are drug resistant. Majority of patients experienced substantial and long-lasting seizure control after surgery. Identifying the epileptogenic foci or network that are responsible for recurrent seizures post-operatively remain at the forefront of epilepsy research to improve seizure outcomes. The first anterolateral temporal lobectomy for TLE was performed by Penfield in 1928. He was joined by neurophysiologist Jasper and later succeeded by Rasmussen. After an early burst of enthusiasm for surgical treatment of epilepsy in the 1950s, there was widespread disappointment with this approach. Rasmussen, the premier epilepsy surgeon, commented, "It was the wrong surgeons operating on the wrong patient." Various studies and meta-analysis over the last 2 decades have shown that the cumulative probability of continuous seizure freedom after surgery was about 83.9% at 1 year, 77.8% at 2 years, and 65.6% at 10 years. TLE surgery failed in 20 to 30% of cases, and 5 major causes are commonly identified. 1 being insufficient resection of mesotemporal structures, 2, insufficient or non-resection of temporal neocortex, dual pathology, activation from the contralateral temporal lobe, and extratemporal and temporal plus epilepsies. With the advances in neuroimaging, it is also estimated that 30% of patients with TLE have no evidence of hippocampal sclerosis on MRI. These are called MRI negative TLE. Compared with the well-defined MTLE, in which the atrophied hippocampus is nearly always the epileptic foci, MRI negative TLE may be a heterogeneous condition, either as a result of variable seizure onset or spread pattern. MRI negative patients are less likely to be considered candidates for surgery than lesional patients, and when operated upon, have inferior surgical outcomes overall. So what is pseudotemporal epilepsy? Recurrence from an extratemporal focus after a temporal lobe resection is reported in 14 to 20% of cases. It is well recognized that some cases of extratemporal epilepsy syndromes can be mistaken for TLE syndrome based on the clinical manifestation and scalp EEG. Also, some seizures arising in the extratemporal areas can remain nearly asymptomatic until they spread to the temporal lobe, where they can trigger a TLE syndrome. These cases are designated as pseudotemporal epilepsy. This slide shows a schematic representation of potential foci responsible for seizure persistence following temporal lobe epilepsy surgery. The pseudotemporal epilepsy masquerading as temporal lobe epilepsy arising from the orbital frontal cortex, the insula, and the occipital lobe. The clinical features of pseudo-TLE are as follows. Seizures began with atypical or no auras, prominent motor manifestations or early progression to motor seizures. Scalp EEGs was non-localizing. MRI showed no hippocampal sclerosis. PET was not definite, did not show any definite hypometabolism. And ictal spec neuropsychological assessment, the WADA tests were generally non-lateralizing, and there was poor surgical outcome. Therefore, these patients were considered to have lesional, non-lesional extratemporal lobe epilepsy or pseudo-TLE. This table illustrates the various atypical clinical features in patients with pseudo-TLE. Though the clinical manifestation and scalp EEG may represent TLE, these atypical clinical features should alert the possibility of pseudo-TLE and that the epileptogenic zone lie outside the temporal lobe. In such patients, further investigations with invasive EEG recording is needed. The distribution of IEDs can be very helpful in terms of searching for extratemporal lesions. IEDs in MTLE often remain limited to the temporal lobe region. IEDs in pseudo-TLE spread over different extratemporal regions and subsequently propagate over temporal areas. Hence the name pseudotemporal. These are the electrode positions for invasive EEG as recommended by Irina et al. The positions of electrodes in the left extratemporal lobe structures are as follows. The orbital frontal cortex as mentioned as O, the frontal operculum, the parietal operculum, and the cingulum. Therefore, one should be aware of the pseudotemporal TLE, and atypical clinical features should be carefully looked for. In such patients, intracranial EEG evaluation, especially for patients with no lesions on MRI, is necessary. 3D reconstructed 3 Tesla MRI with quantitative and voxel-based MRI analysis increase the diagnostic yield. PET and SPECT should be individually tailored. Thus, reliable integration of all the structures and functional data will help to establish the origin of the seizures, and unwanted temporal resections can be avoided. Now we move on to paradoxical epilepsy. Intracranial EEG recordings have shown that seizures in MTLE originate in the sclerotic hippocampus. However, studies have shown a distinct subtype. Clinical presentation is indistinguishable from MTLE with no hippocampal sclerosis. In these patients, there is no evidence of hippocampal sclerosis on MRI, but the histopathology shows minimal neuronal loss. This MTLE subtype is designated as paradoxical temporal lobe epilepsy. A retrospective analysis of the pathology of 151 hippocampi from patients with medically intractable TLE for a period of 10 years was reviewed. Based on the neuronal density, electrophysiological data, and surgical outcome, they were classified into 5 subtypes. 60% of patients had mesial temporal lobe sclerosis, of which 50% had loss of hippocampal neurons with hippocampal atrophy. And they also showed high excitability of the hippocampal dentate granular cells. 12% had paradoxical TLE, and they showed 25% loss of principal neurons in the CA fields. And they also showed low hyperexcitability of the dentate granular cells. 28% of patients had mass-associated TLE, often gliomas or hamartomas. The last 2 subtypes were based on immunohistochemistry studies. This is an interesting report from Zaveri in 2001, which showed that the power spectral density is greater than in PTLE patients than in MTS patients. Therefore, they found that the delta and theta band power measurements of the 2 subtypes were significantly different. This suggests that substrate differences in cellular composition and connectivity between PTLE and MTLE. On comparing the clinical features between the 2 subtypes, febrile seizures were more common in MTLE patients than PTLE patients, and trauma, meningoencephalitis, or perinatal injuries were more often seen in PTLE patients. And the mean age for the first seizure occurrence was earlier in MTLE and later in paradoxical TLE patients. And secondary generalization of seizures were more common in PTLE. MRI showed typical changes in MTLE, whereas in PTLE patients there were no atrophy or no increased T2 signals. Electrophysiological studies of the dentate granular cells showed more excitability in MTLE compared to PTLE patients. And pyramidal cell loss in the CA subfield showed 75% loss in MTLE compared to PTLE. The PSD peaks as observed in the delta and theta bands were also more prominent in PTLE patients, and the response to surgery was better about 80% success rate in MTLE as compared to the PTLE group. The hippocampus, being the corridor of least resistance, propagates complex electrical activity received from the extrahippocampal epileptic network. This epileptic network may originate from a functionally silent part of the cortex. It may manifest itself electroclinically through the hippocampus, producing stereotypical limbic seizures. Therefore, surgical resection of the anterior medial temporal lobe may not be quite successful, as a small part of epileptogenic foci might have escaped resection. So, the correct identification of epileptogenic focus is essential in improving the efficacy of surgical treatment. So, in summary, patients with MTLE have typical temporal lobe seizures, whereas in patients with pseudotemporal have seizures beginning with atypical or no auras and prominent motor manifestations. And patients with paradoxical TLE have a clinical picture similar to MTLE. And the first seizure usually starts later in life, and secondary generalization of seizures is common. The epileptogenic zone is usually in the hippocampus, amygdala, parahippocampal region, or the entorhinal cortex in MTLE, whereas seizures can originate in extratemporal structures in pseudo-TLE. The location of epileptogenic zone remains unresolved in paradoxical TLE, and seizure onset may occur in the hippocampal subregions and spread to involve it during the early stages of seizures. EEG is well localized. Rhythmic theta discharges are seen in MTLE, whereas in pseudotemporal epilepsies, lateralized irregular delta slowing and non-lateralized discharges may be seen. And in patients with paradoxical TLE, EEG findings are quite similar to MTLE. The intracranial EEGs localized to mesial temporal structures and the hippocampal structures in MTLE. It can be variable onset and localizing to the extratemporal cortex in pseudo-TLE, and in paradoxical TLE, it mainly localizes to the hippocampus. MRI in MTLE shows atrophic hippocampus with hyperintense signal on T2 and in MTLE patients, and the MRI in pseudotemporal is usually negative. And in patients with paradoxical TLE, the MRI is negative or may show minimal hippocampal atrophy. Going to the histopathology, in MTLE, astroglial proliferation with significant neuronal loss, about 60%, can be seen especially in the end folium, CA4, CA3, dentate, and CA1 sectors with relative sparing of the CA2 sector. The histopathology in pseudotemporal epilepsies shows no hippocampal sclerosis. And in paradoxical TLE, there is 25% cell loss of the CA4 sector with a relative preservation of CA1 and CA2 subfields. The surgical outcome in MTLE has an 80% seizure freedom, and in pseudotemporal epilepsies have poorer surgical outcome, about 40% from an unselected series. And in paradoxical TLE shows about 50% seizure freedom. So to conclude my presentation, nearly 30% of TLE patients are resistant to drug therapy. Hence, surgery has been attempted on them since 1950. Results of surgery were not consistent. Based on MRI, reclassification of TLE into subtypes became necessary. And they were further classified into MRI positive cases with hippocampal sclerosis, which do well on surgery and have a success rate of 80%. And MRI negative cases were seen in 30% of cases. And this was further subclassified into pseudo-TLE and paradoxical TLE. So in pseudo-TLE, seizures start in the extratemporal lobe structures and later spread over to the temporal lobe region, therefore mimicking TLE. Surgery is least successful in these cases. And for paradoxical TLE, there is minimal atrophy of the hippocampus, but with abnormal electrical activity originating in the medial temporal lobe structures. Surgery is fairly successful in these cases. Thank you.
Thank you, Dr. Shalini, for a wonderful presentation, very comprehensive. And I would also like to thank Dr. Soumya for a very good presentation too. Both of you have covered the topics really well. I could not introduce Dr. Shalini because of some technical issues. She's currently based in Malaysia. She's a faculty in the University Technologica in Malaysia, and she's an epileptologist. She's an associate professor of neurology, and she did her initial medical training in India. And her father is also a senior neurologist. So I think he's part of the audience. So we should probably hear from Sir sometime later. So what I will do is I will now summarize points from these two presentations. Since they've done such a good work, my job becomes easy. So I'll keep it brief. Is my slide visible?
Not yet,
sir.
No, not yet.
Okay, 1 minute.
Yeah, it's ready now.
Okay.
Yeah, it's there now. You can go for full screen.
Yeah, I'm going now. Is it clear?
Yes, very well seen.
Okay. So basically, we'll have to look at why this kind of a terminology came into vogue. This concept of temporal plus epilepsy, it was brought into regular use by Kahane and group. But the concept has been around for several decades before that. We should know that temporal lobe epilepsy is the most surgically remediable epilepsy. And the mesial temporal structures like hippocampal sclerosis has always been the most common surgical substrate. So when epilepsy surgery became more and more widely used in the 1950s, they had initially very good results. But subsequently, they realized a lot of patients did not achieve seizure freedom, or some of them came back after an initial period of seizure freedom. And they had done probably adequate surgical resection of the standard anterior temporal lobectomy and amygdalohippocampectomy. So then various investigators started looking at why these patients had surgical failure. And that's how the concept of temporal plus epilepsy, pseudotemporal epilepsy came into being. So basically, to try and make this focal epilepsy as a localized phenomena in a particular part of the brain, that is too simplistic a concept, because the temporal lobe seizure generators can be quite complex. And that's why we have gradually transitioned now to the concept of epileptogenic networks. So this better explains the complex connections between different lobes and how they can be part of the same epileptogenic network in generating the seizures. And it is this concept that also explains why a good number of patients who have so-called temporal lobe epilepsy undergo surgery with probably concordant clinical and electrical and radiological data, and yet come back with seizures. So this is to understand the concept. This is our classical mesial temporal epilepsy.
Dr. Pramod, can you off your video?
Can you hear me?
Yeah, we can hear. We can off your video. You can off your video. So we can. It's hanging actually. We can just. I mean, because it's the network.
Okay. I'll do that. Can you see it now?
And now it's okay, sir. It's
okay. All right. Yeah. So we will visit these terms now one by one. This is the standard temporal lobe epilepsy. The epileptic generator or the network is largely located within the temporal lobe. And this is where we get the classical clinical features of mesial temporal lobe epilepsy. We have a scalp EEG and interictal EEG that localizes to the temporal lobe on one side, unilateral. And the radiology will show a classical pathology like a hippocampal sclerosis. Invasive EEG in such a patient, not required, but if you do it, it will show ictal onset in the temporal lobe, and an amygdalohippocampectomy, you have excellent surgical results. Now with that, compared to that, what is paradoxical temporal lobe epilepsy? Here too, the epileptic network or generator is within the temporal lobe, and therefore the clinical features do look like temporal lobe epilepsy. There may be some odd red flags. The scalp EEG also localizes to the temporal lobe region, but the problem is radiologically, you can't make out any changes in the temporal lobe region, the mesial temporal structures. Such patients end up getting selected. Such patients end up getting selected for invasive intracranial EEG, and then you find that the ictal data also localizes to the temporal lobe. And such patients have good surgical results when they undergo the standard ATL-AH. Then we come to temporal plus epilepsy. Here, the network is much more complex. You have an epileptogenic network that includes the temporal lobe, but extends beyond the temporal lobe to involve adjoining nearby structures, which could be the orbitofrontal cortex, insula, the operculum, or the temporoparieto-occipital junction. So this term has been used as a unifying term for a multilobar epilepsy, where one of the lobes involved is the temporal lobe. Along with that, the network involves additional areas. So earlier, people would call it as frontotemporal if it involved orbitofrontal region. They would call it temporoperisylvian if it involved insula and opercular region. And they used to call it temporoparieto-occipital epilepsies. So now we have one unifying term which says temporal plus epilepsy. So the clinical features can largely resemble temporal lobe epilepsy, but if you carefully ask questions, you will get some red flags, which Dr. Soumya and Dr. Shalini have mentioned. The scalp EEG will also suggest temporal lobe epilepsy, but again, you may see some ictal and interictal changes that will raise suspicion. MRI may show a mesial temporal sclerosis, or it may not show an EEG. And when you do that, you can detect ictal onset, which is simultaneously from temporal and adjoining extratemporal regions, or you could have ictal onset from one location and another ictal onset from an extratemporal location. And they may also have slightly differing semiology, but the entire network is one. So if you look at just the clinical scalp and radiology, you can't really differentiate a temporal plus epilepsy from a regular temporal lobe epilepsy. Of course, with experience, you might pick up certain red flags that will help you. And you always need an intracranial EEG to make this distinction and to confirm it. Then there's an issue of onset and propagation. So you may have a seizure that starts in the temporal lobe and then it spreads rapidly to extratemporal areas. Now, this is not temporal plus epilepsy. Here, the extratemporal area is not part of the network. It is just the signals are proper. So, for example, in temporal lobe epilepsy, you can have frequent insular spread. So this is a good example. So you have symptoms that look like temporal lobe epilepsy. You also have symptoms later on that suggest an insular involvement. But when you do an ATL-AH, these patients do well, even though you have not operated on the insula. Then you have another concept of temporal plus and dual pathology. So in temporal plus epilepsy, you have one contiguous epileptogenic network involving the temporal lobe and adjoining extratemporal structures. Whereas in dual pathology, you have a distinct extratemporal lesion which coexists with a temporal lesion, which is usually a mesial temporal sclerosis, and both are independently epileptogenic. The temporal plus epilepsy is functionally and anatomically connected. It's a connected network. Whereas in dual pathology, you have two foci which are functionally and anatomically separate. And usually the temporal plus epilepsy generates a single seizure type, but in that one network, you can have activation of different parts. Therefore, the semiology may differ. And you may have two different semiologies happening because the seizures arise from different parts of the network. Whereas in dual pathology, you have two distinct networks, two distinct pathology, and you'll also get two distinct seizure types. Then we come to what is called pseudotemporal epilepsy. So here the epileptic generator is located outside the temporal lobe, and this generator is silent clinically, and once it activates, it propagates to the temporal lobe and produces symptoms. So the temporal lobe here is a symptomatic zone, so it mimics temporal lobe epilepsy clinically, and because some of these extratemporal locations may be deep and not amenable for scalp EEG recording, the actual recording that you get may be from the temporal lobe. So they can mimic temporal lobe epilepsy clinically and on EEG. So clinical features will look like temporal lobe epilepsy, scalp EEG also, but MRI does not show temporal lobe changes. You need invasive EEG, which will confirm the extratemporal ictal onset and subsequent propagation to the temporal lobe. Here, the surgical result will depend on how well you have identified this extratemporal focus. And there can be many different locations. So I've just listed all this published data. You can have orbitofrontal, anterior and posterior cingulate, insula, parietal lobe, occipital lobe. You can have diffuse band heterotopia, periventricular nodular heterotopia, hypothalamic hamartoma. All of these can propagate to the temporal lobe. And since these are all mesial structures or they are not close to the scalp, you may miss the electrical data from on scalp EEG. So this study, which Dr. Soumya also showed, where they attempted to see whether the ictal and interictal data can be used to differentiate temporal lobe epilepsy from temporal plus. And they also looked at the clinical data. So she has already mentioned in temporal lobe epilepsy, they usually report an ability to warn at onset. They have prominent digestive aura, gestural automatisms, and post-ictal amnesia. In the statistical analysis, these were the ones that came out significant in favor of temporal lobe epilepsy. Whereas for temporal plus epilepsy, the auras are gustatory, vestibular, auditory. They have contralateral versive movements of head or eye, piloerection, ipsilateral tonic motor signs, and they can have bilateral spikes or bilateral slow waves, precentral spikes or slow waves, and the ictal onset may not be classical temporal. You may see involvement of anterior frontal, temporoparietal, or precentral regions. Then this is the hippocampal sclerosis and neocortical epilepsy. So they looked at these three groups, and what they concluded finally is that the ictal onset pattern and the subsequent pattern of the ictal activity could not reliably distinguish the three groups. And we always learned that rhythmic temporal theta is a distinctive ictal pattern in hippocampal sclerosis. But here it was noted in all three groups, and they could not show that it was more common or significant for localization to the hippocampus in mesial temporal sclerosis. And only thing that they found out was that all the pseudotemporal seizures, they spread to the contralateral hemisphere at some point of time during the seizure. So if you see a strictly unilateral seizure, ictal, maybe it's not pseudotemporal, but that's not good enough to make a distinction. So when you are faced with this, when you have to diagnose temporal plus pseudotemporal or paradoxical TLE, finally, the confirmation is by invasive EEG. And this again is a problem because in a particular center, you may have different indications for invasive EEG, and the protocol used and the extent of coverage, that also varies. So how well you pick up these entities depends on the protocols that you have in place at your institution. So normally people select patients for intracranial EEG when they detect some red flags in the history, in the scalp EEG and radiology. But all these red flags are actually non-specific. And whereas the coverage and the protocol followed depends on what kind of temporal plus syndrome you have in mind. So frontotemporal, then the coverage will be different. Temporal perisylvian, the coverage will be different. And normally you have to have a large sampling, large spatial sampling, so you test results. So this is just a general guideline regarding when to resort to intracranial EEG in what we call as temporal lobe epilepsy, which may not be so. So this has been mentioned by Dr. Soumya and Dr. Shalini. There are some clinical red flags that you can use. Red flags on scalp EEG, when the ictal activity or interictal activity is not a classical temporal lobe epilepsy. Radiology red flags, any MRI negative TLE, you should definitely consider intracranial EEG. Now, what is the implication of this? So there is clinical indications in that the temporal plus epilepsy, the pseudotemporal epilepsy, they tend to be more difficult to treat. The seizures tend to be more frequent, clustering is more common, and there's the secondary generalized seizures are much more in these compared to seizures arising from hippocampal sclerosis. And of course, when you consider surgery, you need to identify these entities to prevent surgical failure. And if you identify them correctly, you can plan your surgery better so that you have improved surgical results, because you can, any of the TLE studies, the temporal lobe epilepsy studies, are contaminated by the presence of temporal plus, and the sums of hippocampal sclerosis and other mesial temporal epilepsies are kind of distorted. So maybe with better identification of these entities, we'll have more pure TLE groups to evaluate. Temporal plus epilepsy is also considered as a specific risk factor for SUDEP. So this is because when the insular cortex is part of the epileptogenic network, it can produce cardiovascular instability, and also these patients tend to have secondary generalized seizures more. So this combination can be a risk for SUDEP. This is a major study that showed that temporal plus epilepsy is one of the major reasons for surgical failure in patients with temporal lobe epilepsy. They had 168 patients, of which 10% turned out to have temporal plus epilepsy. And look at the outcome, just 14% class 1 outcome for these patients. So when they looked at various causes of failure, which both the previous speakers had listed, one of the significant determinants was temporal. To conclude, you need to distinguish temporal lobe epilepsy, pseudotemporal lobe epilepsy, temporal plus syndromes. This is very crucial for better surgical outcomes. In some cases, they can be suspected clinically, but scalp EEG and MRI cannot reliably distinguish these groups. Confirmation requires intracranial EEG, and if you can do it correctly, then you can have good surgical results in all these groups. Thank you.
Thank you. You have really covered it very nicely, Pramod, and very, very important topic which has been covered by all the three speakers nicely. So I think first we can take question answers before going to any next step.
Yes, so we have a question here where somebody asked, what is the importance? Is it only for patients who need surgery, or is this distinction important even if you're not considering surgery?
Yeah, so at least this particular part, the today's topic discussion was mainly on something like how can we differentiate temporal, pseudotemporal, temporal plus, and paradoxical temporal. So this kind of distinction is mainly required from surgical point of view, and this has been nicely covered. I think everybody is clear that temporal, pure temporal is when there is clear-cut MTLE, where there is MTS. Paradoxical is when the hippocampus is absolutely normal. Temporal plus is when temporal is involving in continuation the other part of the brain, and pseudotemporal is when the temporal lobe is okay and the seizures are coming from some other part of the brain. So all this differentiation is important purely from surgical point of view, as medical management is more or less same. Pramod, you can add.
Yeah, so only thing is that in temporal lobe epilepsy due to hippocampal sclerosis, you generally tend to get complex partial seizures with focal seizures with impaired awareness, but the secondary generalized seizures are not common. So that way, the pseudotemporal and temporal plus tend to have more likelihood of secondary generalized seizures. So there's safety issues related to that. But as far as management is concerned, medical management is concerned, it would not matter too much.
Great.
So there is, this other question. Clinically, how do you suspect temporal plus epilepsy versus pseudotemporal epilepsy?
So I think we have already covered this particular point, that temporal plus means when the temporal lobe itself is involved, and pseudotemporal when the temporal lobe per se is totally normal from structural point of view. So in pseudotemporal is the semiology which is more looking like temporal, but the pathology is not in the temporal lobe. In temporal plus, the pathology is in the temporal lobe as well as adjoining brain areas. You can comment something, Pramod. And Neeraj is there. I think Neeraj can.
Yeah.
Yeah.
Neeraj, Dr. Soumya, Dr. Shalini, all of
Yes. Yes, sir.
Yeah, exactly. Okay. Yeah.
Clinically, to differentiate between pseudotemporal and temporal plus would be difficult, because pseudotemporal it can like, even though the pathology is extratemporal, there can be a rapid spread to the temporal lobe, causing like ictal manifestations which are similar to a temporal lobe epilepsy. So it actually requires a evaluation with an EEG, like either electrophysiological or MRI features, as sir has already mentioned in those tables. With that only, like a definite distinction, a reliable distinction between the two entities can be made. Purely clinical, it may be difficult to differentiate in some cases, because both may have temporal, both may present with a semiology similar to a temporal lobe epilepsy with any of these red flags which have been mentioned.
Dr. Shalini,
Yeah, so
Yes, I think, yeah, sure. I think Dr. Soumya has explained just now. The temporal lobe, temporal plus epilepsies are from the temporal lobe to the extratemporal areas, and extratemporal or pseudo TLE is when the seizure starts from the extratemporal lobes and propagate to the temporal lobe. As I mentioned before, the hippocampus is an area which is very sensitive, and so when the epileptogenic zone is around the temporal lobe, it can pick up. So.
yes,
I think invasive.
it's on the same lines. This is another question. Sorry, Dr. Shalini, continue.
No, that's why invasive EEGs are the best, to diagnose. Clinically, it might be very difficult to differentiate, but invasive EEGs would be warranted in these kind of patients. Thank you.
Thank you, Dr. Shalini. Any other questions?
Can I ask one? Rajesh Iyer.
Ayarji, please. You are welcome.
Namaskar. Yeah, see, this paradoxical TLE was something what I heard of when I was doing my fellowship. After that, this term has hardly been used in many places. Is it just that it is MRI negative temporal lobe epilepsy, or is there anything more to that than what we understand as of now? Or is it just a term for describing a temporal lobe epilepsy without an evident mesial temporal sclerosis?
Yes, sir. That's what I understood from all the papers. It's like an MRI negative temporal lobe epilepsy, but the classical hippocampal changes are not seen, not only on MRI, even on histopathology. Very minimal changes are seen even on histopathology, but it behaves otherwise like a temporal lobe epilepsy, sir.
Is the term still in use?
The last paper I read was 2017-18. So till then I could see it. I didn't come up with any more recent papers, sir.
So the concept still stays, Is it that there is a separate entity called paradoxical temporal lobe epilepsy, or it is just one of those, non-hippocampal temporal lobe epilepsies?
I think it is more or less same as MRI negative epilepsy.
Non-lesional TLE.
Non-lesional.
Non-lesional TLE. Okay, fine. All right, thanks. Yeah.
Sir, one doubt, sir. If the PET is positive in these cases, should we do invasive in this paradoxical TLEs? The PET is positive. Suppose PET is showing temporal hypermetabolism. So will you do invasive or not? The paradoxical TLEs.
Dr. Shalini or Dr. Soumya, question is, if you have classical TLE, which is MR negative, PET positive, would you go directly for surgical, or you would like to have an invasive monitoring in this sort of scenario? Because now discussing all this.
Sir, surgical, yes, Dr. Shalini can.
Dr.
Yeah,
Shalini?
I think if there is a doubt, I think it is best to go for an invasive intracranial EEG monitoring, because we will be more sure of where is the epileptogenic zone, and we would not be unnecessary putting patients for resections.
You agree, Dr. Soumya, or you want to add?
Yes, sir. Because the surgical outcome is good in case of if a correct epileptogenic focus has been identified. Because most of these will be drug-resistant epilepsies, and they might require detailed evaluation to correctly delineate the epileptogenic focus. So better to go ahead with an invasive EEG monitoring. If it comes negative, then it may be a paradoxical TLE. And with maybe the post-surgery also, it can show the histopathological changes in about 25% of the cases, as already mentioned by Dr. Shalini, for paradoxical TLE. And in the other one, a correct epileptogenic focus can be identified, and the patient may remain seizure-free post-surgery.
Pramod, you differ or you agree on the same lines?
If you're talking about
classical TLE with classical semiology, maybe febrile seizures at plus minus at the onset, no secondary generalized seizures, classical TLE spikes and rhythm, but MR is negative and PET is classically PET showing hypometabolism at mesial temporal structures. All of us.
So what I've
so
what I've understood from all these papers which I've reviewed is that things that we use for distinction, like febrile seizures, antecedent illness, a classical ictal rhythm, actually none of them can be reliably used to distinguish these entities. So febrile seizures were present in a good number of patients with temporal plus and pseudotemporal, and the ictal activity that we look for, the rhythmic temporal theta, also present in many of these entities. So I would not be comfortable with PET alone, and I would definitely look at an invasive EEG in an MRI negative patient.
Ma'am, Ashalatha madam is there. Madam, what is your opinion of TLE? We used to take separately MR negative TLE, PET positive. Does it still holds true that all MR negative cases TLE should also go for invasive, like what we do for extratemporals, or in a selected substrate we can still go? Because invasive again is the issue at many centers in our country. I mean, yeah, but then scientifically, what should be the take home? The gist of it.
Thanks, Neeraj. The most difficult question finally has come to me. So the reason why I put this topic is that I myself is so confused reading every year. All the three terms are used in almost they overlap with each other in many of the features. Like somebody was saying that 2017 paper on paradoxical TLE, right? It underscored the fact that it should always be MR negative. So if I can ask you a question, temporal plus epilepsy, which is being overloaded now, wherever you go, this temporal plus is some with like a Big Bang theory now. So if the MR is negative, but you typically have insular features, so, and the PET is showing everything. I'm just giving you a hypothetical situation in which the PET is showing the, it's confined to the visual temporal structures. What will be your take on that? First question is it temporal plus or it's MR negative? You mean the paradoxical TLE, or could it still be a pseudotemporal epilepsy? Nothing in the insula. 3T MRI, Keshavji and Bijoy has seen. For us, they are the final takers, so nothing is there. So the first question to Neeraj and Atma is, what terminology do you want to call here? Some insular features are there, not all of them, but still. Some gustatory aura, some hypersalivation. Otherwise looking like, I always teach my students these days, TLE like semiology. The rest we will see. So my PET is also positive. So first of all, the question to both of you, because you are two senior persons now, would you want to call it a paradoxical TLE, or it could be still a pseudotemporal epilepsy, or you want to put it in the basket a paradoxical temporal plus syndrome? After that, the second question I'll ask, and then I'll give you the answer, whatever I know.
Ma'am,
Yes.
you can't say it as paradoxical if the PET is positive. And
you can't say it is paradoxical. So PET should always be negative in paradoxical. That is what you say?
No, that's not.
That is because the PET is also not classical temporal. It is not. It's not temporal. It's, you are saying insular. So
insula is by semiology. You have a TLE like semiology, but you have something to suggest that there is something like an insular features are also there. For example, some hypersalivation, some gustatory aura, or something, maybe. Not the classical insular. MR, 3T MR is negative, but the PET is positive. PET is positive in the sense it is in the mesial temporal region that the hypermetabolism is seen. And I think you can do a SPECT also that is showing hyperperfusion in the mesial temporal lobe. The question is, would you like to call this as a pseudotemporal or paradoxical or temporal plus?
It's $1 million
question
you are asking.
It's a $10 million question, Atma. Any of you can answer, no problem. This is, I do not know the answer. That's why I put the topic per se, because these terminologies are confusing the people like anything. Earlier, there was only temporal lobe epilepsy and there were red flags, if you remember right, when you people were there. We did not want to give too much of importance to all this. Then in 2007, this temporal plus came from somewhere. 2005, somebody started it off, and everything is either temporal plus or it can be extra temporal propagation. These are the two things which are very, very common here, but there are other things which are also possible. For example, there is an occipital lesion and it can clearly look like a temporal lobe epilepsy. So what terminology are you going to give it? Extra temporal with a temporal propagation. That is in reality. But if you want to give a terminology, what would you choose from this?
Pseudotemporal.
Pseudotemporal. That part is correct. I'm also very much agreeing to that. I'm just confused about this paradoxical TLE and the temporal plus is okay, fine.
The TLE with some insular features, we can still subgroup into TLE plus sort of thing. Where we know its major junk is TLE, but then there are features, some atypical features. And in past, many of these cases, there's one or two of these features, we used to just keep it aside and we used to take this sort of cases. So maybe why I asked you, because on long term only with failures, we might learn, and maybe that's the reason I thought you will be the best person to answer this.
So now coming back to your question, petectomy came up in a big way, I think from the Australian group. You know the person also, no? So there were two important papers, one in epilepsy and one in brain came. But it did not take off that smoothly, because most of the people world around started doing the PET positive resection. That area would be resected out, but the outcome was not very good. So I think we have 3 patients who were resected just based on petectomy, in which one RIA, I think, I'm telling the name because it might be one of your patients. Most of the PDFs are here today, thank God. So you may be thinking about this Ria Varghese. She's doing quite okay and she's out of medicine also. And if you compare that particular lady with 2 other people who have failed, they are looking almost the same. TLE like semiology, all unilateral IEDs, anterior-temporal and mid-temporal IEDs. And we did the PET, and the PET was confined to the temporal region. And we did a standard ATL. 1 was left and 2 were right, actually. I looked into this data for these people's scan presentation recently, so that's why I remember about it. So 1 had actually a good outcome, the other 2 did not have. But in the other 2, we should have a hypothesis where to put the electrodes. When you don't have a hypothesis, you're gone. You can easily say that invasive will solve the issue, but invasive is not going to solve the issue unless you have a very hypothesis-driven approach. So in that case, where I pointed out, you can put some electrodes in the insula and in the mesial temporal region. If you get a, good ictal onset, good. Otherwise, you'll have to drop the case. So it's not a very easy task. Pseudotemporal is good. Extratemporal to temporal propagation. And that is also great when you have a lesion outside. When you don't have a lesion, you are gone. When you don't have a hypothesis, you are gone. So a person who don't have any aura having a temporal semiology, and you see some IEDs in the parietal and occipital region, I'm just giving you a presumption. And on the same side, you get a nictal onset, which is unihemispheric. Where will you put your electrodes? Nowhere. You cannot just poke in electrodes in the big parietal lobe on one side and in the whole occipital region and in the temporal region. Then only frontal is left out. Why don't you cover that also? So half a cap of electrodes is what you're going to do. So that is also not easy, but at least you know the concept of pseudotemporal epilepsy. There is an occipital gliosis and the rest everything. Which vesiculus, Soumya? You were talking about vesiculus in great length and breadth. Which connects occipital to temporal?
Yes, ma'am. Inferior fronto-occipital fasciculus is there, and the inferior longitudinal fasciculus.
Yeah, inferior longitudinal fasciculus is a correct answer. Occipital to temporal. So that is pseudotemporal epilepsy. When you have a lesion, it's okay. But between paradoxical TLE and temporal plus, one is, according to the most of the authors, is MR negative most of the time. That's the only point which I thought was pointing them towards paradoxical TLE. But Rajesh's question is troubling me also. So I'm not very sure. Pramod, what is your final take, ma'am?
Ma'am, if it's a
pseudotemporal, you leave. I'm confused about this paradoxical and temporal plus.
Ma'am, if a patient has a classical history of temporal lobe epilepsy without so-called red flags, and the only thing missing is a radiological evidence of temporal lobe involvement, and then if you do your study and subsequently confirm that the ictal activity which you recorded on scalp EEG from temporal lobe structures is the same that you get on invasive EEG as well, that would confirm that that patient has a paradoxical TLE. So basically MRI negative TLE, no red flags in terms of EEG, no red flags in terms of clinical semiology. It's just that you don't have a substrate that is visible, and therefore you double check with invasive, and then you don't get any red flags on invasive also. So that becomes a paradoxical TLE. Temporal process where the semiology is like TLE, but there are pointers to suggest that other nearby structures are also involved in terms of clinical semiology or ictal data that is that shows bilateral or extratemporal spikes. Then whether MRI shows pure MTS or not, you would brand this patient as likely temporal plus epilepsy, because you know that MTS will not explain all the clinical points in that particular patient.
So there is a gray zone in between, in which we'll have to take it according to the individual patient. That is what I understand, isn't it, Pramod? Yes, because temporal plus also need not have all the time a mesial temporal sclerosis or a lesion sitting there. Still, you have to have a gut feeling on that. I think we should not go by this terminology so much. It is either a classical temporal lobe epilepsy or a temporal lobe epilepsy without the classical features.
Yes.
And then we have to think whether it is extratemporal or from the structures adjoining the temporal lobe, that is your temporal plus, or in your normal TLE patient. Where to place the electrodes is a big question, which we will not address it today here, because it is all driven by a hypothesis. Pramod was talking about a very classical story in which paradoxical TLE, they have described according to the 2017, 18 and even papers earlier. But that may not be the case all the time. So that is what I think. I think Dr. George, Sharath and few neurosurgeons were there here today. So we would ask them also. Good that so many people turned up today. So you can ask anybody who wants to comment on anything, like Ramesh. So many people I can see here who are staying back. Yes, Neeraj and Atma, you can carry on with some of the people commenting from the group.
I have a point. Can I tell you?
Yes,
Here.
Yes,
yeah, you don't have to ask.
Yeah, I think the paradox paradox was started by the neurosurgeon. I think the first article came in 2005 when they were surprised that there was no MTS and everything looked like mesial temporal of epilepsy. I think there's nothing more than that. And I think Neeraj posed an important point, whether you should operate with PET positivity if the MRI is negative. I think if the abnormalities are primarily temporopolar, then one is justified in operating without invasive. But otherwise, if you have some changes on the MRI, if you look very carefully, like if there's an encephalocele or a subtle change in the gray-white differentiation in the temporal pole, but otherwise it will be a bad decision to operate MRI negative epilepsy without invasive, because even with clear-cut lesional epilepsy like MTS, the outcome in the long run is only 50%, and the outcome heavily depends on the surgeon. So if there's no sclerosis, what are we going to operate upon? So there is a word of caution from my side, having seen so many failures. If it is MRI negative, be sure that it is temporal polar before operating without invasive. Yes.
Yeah, Rajesh, I concur to that. 2004 from RMNC, there was a paper on 23 cases of MR negative TLE, which is many citations, Dr. Shailaja and Sir KR Sir. And as a person sitting in the post-operative clinic after 25 years, or maybe 20 years, our outcome those days was 70% at 2 years, but it has fallen to less than 40% at 20 years. The reasons I have no idea, because only I think 2 or 3 patients underwent a re-evaluation. Re-evaluation, having said it's easier said than done, it's very, very difficult. We don't have a hypothesis, we don't have a temporal lobe, we have a breach effect coming into the picture. And so out of the 23 patients, which then at that time was one of the most cited papers, and even now we will cite it, because we picked up the patients without invasive. Depending upon, because Sir used to tell this very often, they have a classical history of febrile seizures, complex febrile seizures. Then they have the classical abdominal aura or fear. Then they have the classical type 1A IEDs, which is the unitemporal, anterior or mid-temporal IEDs. And they have a type 1A ictal onset pattern. That is a subtemporal theta developing in the temporal chain. So if you have this, and the semiology is also very typical, you go ahead and offer them resection. This was the concept earlier, but at that point of time, 2 years, Dr. Shailaja had looked into that, and they had a very good outcome, 60 or 70%. I was just in the beginning of my career, but sitting down the line, I'm in the OPD now, and most of these patients are coming back and telling us that they are not seizure free, and most of them, I want to look into that, but not getting time these days, they have secondary generalized seizures. So I really do not know. They have picked up the patients in such a way that at that point of time, that was the best patients who could have been chosen for surgery. But having said that, most of them are not doing well. Maybe only 30 or 40% are having a good seizure freedom 20 years later. So this is a dynamic phenomenon. We cannot just say that at 2 years somebody is doing well, so they are going to do so for the rest of their life. Somebody doing not so well at 2 years can be seizure free also. That's a different story. The seizure outcome is a very dynamic phenomenon. So I completely agree with Paya. He was also there. Rajesh was also there when the paper was published. So that is our experience with MR negative. So that was that time called as paradoxical TLE. So I think we'll stick on to that definition. It looks like a TLE. TLE like semiology, and MR negative is paradoxical TLE. And since this is being gone inside our cortex, that temporal plus syndrome will never come out. And now where do you fit this hypothalamic hamartoma and periventricular nodular heterotopia, which has the temporal lobe semiology? So I always keep teaching Soumya and other people. I add 2 more things into this temporal plus syndrome. That is the hypothalamic hamartoma and the periventricular nodular heterotopia also. That's a very, the PNH paper you must have read from Brain, which classically says that the temporal network is involved. When the thing is sitting deep within the white matter also, the temporal network is incriminating. So that should also be included into the temporal plus syndrome. We always look into these 2 pathologies as well. So that is my take. Now you can ask 1 or 2 people, and then we'll close the session. Ramesha and some senior people are sitting there.
Dr. Ramesha, any comments or any points you want to?
Hello, Ramesh here.
Yes,
Yeah, good evening,
Ramesh. We
sir.
were asking you only. Ramesh? Ramesh? Yeah.
Non-lesional temporal epilepsy may be a preferred terminology than a paradoxical TLE, I think.
Yes.
Earlier we were calling complex partial seizure. Now we call it as a dyscognitive seizures. It is the same thing, just for another way of producing more and more papers. And it is confusing.
Are you putting the blame on us also, Ramesh? Without
Agree with you,
papers, you
Ramesh.
can't survive, man. We won't get promotions here. That's the only reason. Otherwise, I would have seen 2-3 more movies than writing all this rubbish. Okay, Ramesh, continue. So, Neera, you may all remember Neera Chaudhary. All of you know her. Neera, just come up telling. Can you unmute Neera Chaudhary?
You can unmute, ma'am, actually. I give an option. Yeah.
Yeah.
Hello.
Yeah, Neera.
Hello. Hello, everybody. Yeah, I really enjoyed the talk, though I'm away from epilepsy surgery now because at the center here, we've not been able to establish it. But it was nice listening to everybody.
That's all, Neera. Doing well?
Yeah, doing well. Thanks for coming, for
Oh,
making me
thanks a
join this
lot.
interesting session.
Oh, thanks. So back to Neeraj and the
Yeah,
three
so ma'am,
speakers.
summarizing, if I have to say MR negative or non-lesional TLE, yeah, you should be cautious, especially all epileptologists who are in budding stage and who have just started their careers and who are doing these epilepsy surgeries. Yeah, I remember 2011, and when last 8-10 years, I have done 2 or 3. They are doing reasonably good till now, but yes, that was the precise reason I thought what happened to them after 15-20 years, we would like to hear from you. And yes, that's the caution that everybody should keep in mind. So, Pramod, you want to add anything to it? Final comments, closing comments?
I think ultimately this final labeling will happen only after invasive. At a clinical level, we will remain in that a stage where we can't really pin a label on it. So we just have to be cautious, work them up correctly, history and EEG to be nicely scrutinized, and if you can't still sort it out, refer to a higher center where this kind of invasive EEG can be offered to these patients.
So summarizing, non-lesional TLE or MR negative TLE should be treated as MR negative extra TLE, where we know we have to straight ahead center them for, they will require a detailed evaluation and might require all where they have invasive monitoring and stereo as possible. Rest of the things will be needed.
The concept was well covered. And if we can wrap up.
Well, so
yeah, Neeraj, it was a wonderful session, and both of you did so well. Chairing is also very difficult, you know that now, no?
Yeah. Thanking you all for joining us on this Saturday evening, and it was a fantastic session and lots of take-home messages. And I hope this weekend you'll all enjoy. But at the same time, many things will go on. Hearing all this, every time when you hear this, and the next case, you will see one of these patients coming up, and so that helps us in our decision making in day to day. Signing off. Goodbye.
Yeah. So all of you are welcome next week also. That is an important topic which is not very often discussed. Men do have reproductive problems in epilepsy, which is not taken care of. We are always concerned with women, especially when it comes to epilepsy. So next week should see you all. And thanks a lot. Thanks, Neeraj and Atma. Thank you so much, all of you.
Thank you, ma'am.
Thank you, ma'am.